Good afternoon. I'm Sherilyn Francis, and on behalf of the National Center for Primary Care, we welcome you to Part 4 of our Opioid Use Management webinar series. We invite you to connect with us at www.primarycarematters.org and via social media at PriCareMatters. The National Center for Primary Care is located at the Morehouse School of Medicine. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals serving in underserved areas. The core principles of the NCPC are access, effectiveness, and equity. Today's webinar is made possible via a partnership with the Southeast Addiction Technology Transfer Center and the Recovery Institute of Southwest Michigan. The objectives for today's webinar are to identify best practices for treating an opioid overdose in various settings, to review the standard guidelines and protocols for treating an opioid overdose, to identify the best practices for communities and care settings working together to treat opioid overdose, and to examine how community-based organizations work with healthcare centers to treat opioid overdose. Today's webinar is CME accredited, and in order to receive CME credit or a certificate, a participant must attend the entire webinar and complete the CME form, which will be emailed within 24 hours following the webinar. Additionally, there is a $25 cost per CME certificate for all non-Morehouse School of Medicine employees. I now present to you today's webinar entitled Integrating Clinical and Community-Based Interventions to Address Opioid Overdoses, presented by Dr. Dominic Mack and Mr. Jeffrey Adams. In compliance with ACCME guidelines, the following presenters have no financial or other relationships with the manufacturer of any commercial service discussed in today's educational activity. And we will begin today's webinar with a recovery testimonial from Ana Castillo. Ana, are you with us? Wonderful, thank you. So Ana will be sharing her recovery path with us today. So Ana, can you please begin by describing your transition into addiction?
Okay, so like when I first started using drugs? Okay, I started when I was 13. It was, I first was using, pills like Adderall and stuff. Then it got to meth, and then I got introduced to heroin, and then throughout time, I got physically and mentally dependent on heroin. So that was just my main focus during my addiction, was just getting high on heroin.
And during your time of addiction, did you have any overdoses?
Yes, I've had a lot of overdoses through when I was 14 to 21. So I think my most crucial overdoses when I got out of rehab in February and decided to use and thought I could use as much as I could when I got out. The rehab gave me 3 Narcan kits. They gave everybody Narcan kits when they left. And if it wasn't for the Narcan kits, I probably wouldn't be here.
And can you describe for us your path to recovery? What initiated your recovery, and what helped you sustain your recovery?
I've tried a lot of things for recovery. When I was about 15, 16, I was in the juvenile drug court program, and that helped because I think the main thing that helped was because I got pregnant when I was 16, so that so I graduated the drug court program successfully. But then shortly after having my son, I just kept using and using. So, but right now I feel like this is my most beneficial recovery that I've ever been in. I've tried the methadone clinic, and that didn't work too well, and so now I signed up for the family drug court program in February, and I've remained clean since then. So I feel like this is the one that helped me a lot and made me not want to go back out and use.
Thank you so much for joining us today and sharing your story. If you can leave our webinar participants with one takeaway message, what would that be?
Like for the people that's still using, or?
So our webinar is composed of a wide variety of health professionals, but also a message for the health professionals, but a message for the patients that they may be treating.
Okay, well, I think the three major things that I think that would help, knowing me that I have tried recovery several times throughout 13 to 21, definitely get into some type of like drug court program. I feel like they need more drug court programs for different situations for addicts, because I believe it helps, other than just getting in trouble and getting forced to do it. So I feel like, yeah, drug court programs definitely help, and to start spreading more Narcan around and make sure that addicts have that and it's available to them. I know that they have Narcans like at Walmart and Walgreens now, and at, you know, the DHS places for free. So I just feel like Narcan helps save lives for people who are using opiates too. So yeah, some type of program and a lot of willingness from the addict is beneficial.
Wonderful. Thank you so much, Anna, for joining us and sharing your story with us. Anna will be available at the end of the webinar for question and answer.
Okay.
And now we will transition to Dr. Mack.
Okay.
Thank you, Sherilyn, and thank you, Anna, and thank the audience for being with us today. Today we'd like to kind of build on Anna's story, and Anna, our prayers are with you, and hopefully this recovery will go well. But along with Anna's story, what we want to try to get across to the audience today, and actually to the community and to the nation, is the difficulty of treating abuse, opioid abuse, but also the problem, the awareness of the problem, the importance of prevention. But as Anna stated, this is something that's difficult to treat once people are addicted. So it affects family, but we know it's affecting the criminal system. It affects the community in multiple ways. So we want to look at a few things today with the next slide. So today I want to talk to you briefly before we go to Jeff about the background of this epidemic, a little bit about the neurobiology and the pharmacology. We'll touch on the symptoms and then the treatment, and Jeff will expound upon that when it gets to his portion of the presentation. But we want to look at it, I want to look at it as a family physician from a primary care, clinical perspective, ambulatory medicine perspective. First of all, I'd like for you to take a look at this, and these are celebrity deaths from opioids and other prescription drugs. The ones in gray were other prescription drugs outside of opioids, but I think it's important, and I want to just give you a moment to peruse this list. I'm sure you've seen somebody who may be a movie star or somebody who you've listened to their music, but people we can identify with, and it just shows the impact of prescription abuse, but also opioid abuse. You know, I used to listen to I still do listen to the music of a lot of these artists. But like Anna's story, it's not only affecting the rich and famous, but it's actually in our homes, in our practices, and a lot of times it's going unawares. We're not really identifying those who are abusing opioids and prescription medication. So first of all, let's just give a quick overview of the different types of opioids. And this kind of helps people to understand what's the difference between the natural and the synthetic drugs like fentanyl, which we hear a lot about today. Opioids come naturally. We hear about the poppy and opium. And opium, I would say, is pretty much the mother drug for morphine and codeine. And those are all naturally occurring drugs. As we know, morphine and codeine are actually used within medication, there's Schedule II drugs, and the difference between a Schedule II drug and a Schedule I drug is basically, for all practical purposes, 2 can be used medically, and 1 usually is illegally when it comes to opioids. When you look at semi-synthetic drugs, you start to see heroin, which we know is only used as an illegal drug, and then you see some prescription medication. Semi-synthetic means basically they're mixed with natural drugs, like heroin is mixed with morphine and other components, which makes heroin and what we see on the street today. The same goes with hydrocodone and oxycodone. They're mixed, they're distributors of opium, but they're also mixed with other substances to make the drug that either is illegal, like in the incident of heroin, but is a prescription in other cases. But when we get to fentanyl and methadone and Demerol, they're fully synthetic, which means they are drugs that are created in the lab to mimic opioid, the natural opioids that we can get from the poppy fields. So these are the various classifications of opioids, and of course, with all of those, we can see abuse in some form or another. And that gets to just an overview of the abuse in the United States. We know there's the illicit use of opioids, and then there's the prescription abuse of opioid analgesics, mostly opioids that are used for pain management. We've talked about this over the series of the opioid webinars that we've been doing, but in 1997 through 2007, there has been a 700% increase in prescriptions. There is a major overlap between mental illness and chronic pain and the opioid abuse, and some of that is because when you have either of these categories of illnesses, you're more likely to use more opioids. And also, when you have pain, you need opioids. But as far as mental illness, there's a high incidence of mental abuse of all type of drugs with mental illness, especially certain forms of mental illness, going from depression to anxiety to schizophrenia. Now, the last 2 bullet points kind of show you the flip. In the 1960s, 80% of the opioid abusers began on heroin, so from illicit abuse. But in the 2000s, 75% of opioid abusers began on prescription drugs. Even those on heroin, a significant portion, over 50% of the people on heroin today began on prescription medication. So therein lies the problem with prescription opioid analgesics. And of course, we're talking about adult overdose, but let's kind of look at just the problem with this. It's the prescribing practices play a big part of the opioid problem. You probably heard a lot about that. That it's the prescriptions. Some people blaming the docs, the providers, and the providers are blaming the pharmaceutical companies. Wherever the problem lies, the prescribing practices have to be changed if we're going to change this problem. A lot of it is proper patient education, or just their misunderstanding of the risks. So they misuse opioids, and that can lead to abuse, but also overdose. And then there are errors in drug administrations, which can happen in a hospital. For instance, there have been overdoses when a patient can be administered the wrong amount. We always hear about overprescribing. Somebody comes in for elbow pain, for example. They might have had surgery and they're given opioid pills for 2 months. So drug administration, overtreatment is a big part of it. And then there's pharmaceutical abuse, where opioids can be sold on the street. We've heard of these, especially in Georgia recently. We've heard about the closing of a lot of pill mills where patients would just go into these doctor's offices or these provider offices, and it was basically a front for distributing pills. So therein lies the problem, and each one of these increase the possibility of abuse, but also overdose on opioid analgesics. I'm sorry. So overall, the danger of abuse is, opiates have toxic effects, especially in high doses, on many body organs, the GI tract, pulmonary, respiratory tract, and other tracts that most of us know about in health professionals. The duration of the drug can vary to the formulation. As we know, especially illicit drugs, there can be all type of substances that are mixed in with the opiates to make it more powerful, or just to kind of that's just part of the drug culture to bulk up the amount of drugs that are distributed. And then the overdose can disrupt normal pharmacokinetics. When someone overdoses, and I'll talk more about that, and you have a toxicity of drug within your body, that can change the pharmacokinetics and the way that the drug is broken down. So that can lead to overdose. Just want to point out that fentanyl and fentanyl analogs, which are basically fentanyl, which is, as we say, is a synthetic drugs, but then there are illegal labs out there that are actually making the analogs to mimic the fentanyl. Why is fentanyl so popular? And also fentanyl is used a lot out there on the streets because it's highly potent and fast-acting, 50 to 100 times more potent than morphine. And it's commonly mixed with heroin and cocaine, and commonly found in the heroin mixture in these overdoses, and that Jeff will tell you more about. And it's primarily responsible for the 5-fold increase in overdoses. You probably heard that in many towns. Recently in Atlanta, it's been on the news about fentanyl being found in many other cases of heroin overdoses. And fentanyl, of course, was associated with Prince, the musician, death recently. And as I stated, most analogs, fentanyl analogs, are mostly illicitly manufactured. So opioids, a little about the neurobiology and the pharmacokinetics, which is the absorption, the onset, and the clearance of medication. The way it works is opioids receptors in the brain, and they're receptors throughout the body, but heroin, for instance, is broken down into morphine. But you have those opioid receptors, and these receptors absorb the opioid, and then the opioid can in turn affect the dopamine within the body. You have neurons which basically release dopamine, and that's how you get these different effects neurologically but also physically. And they both can have effect on the respiration. In your body, when you get too little oxygen or too much carbon dioxide, the system, the respiratory system, the cardiovascular system, etc., it reacts and it responds to correct the imposition on the body. But what happens in the cases of opioid and even with dopamine, as it's released because of opioid, you can have suppression of your respiratory response. So opioid can also form in the gut, and it can form boluses, and what this can do is this is actually change the way the drug is absorbed, the onset of action, but also the clearance of drugs. And basically with drugs, they have to be cleared from the body to no longer get the effect of the drug. And if you have slow clearance, if you have fast absorption, and you have slow clearance, the medication or the drug will remain in the body for a longer period of time. So high drug concentrations which lead to overdose with opioids, what they do is cause a slow breakdown of the opioid substrate, which leads to saturation within the body. So you get where too many, and I'll show you an illustration, but too many of the receptors are saturated with opioids, and then the opioid floats around in the body and it begins to have a deleterious effect. And after saturation, small dose increases can really lead to disproportionate plasma levels. So that means basically all your receptors are saturated, so you can just put a little amount more within the body, and then that can tend to lead to overdose. And then the drug is not eliminated fast enough for different reasons. It could be because of the mixture of the medication, but also, as we stated, it could be the state in which the GI tract is in, but the elimination can increase the toxicity. So this is just a picture of how the opioids affect the breathing. And you can see, as I stated, opioids, their receptors are in the brain. They're also throughout the body, but mostly we're talking about the brain today. And in our pictures, what's not showing up is basically the receptors and the little opioids. So it's not showing up as we thought it would. But what's happening is this picture would show you that there are many opioid receptors, and then it shows that the opioid comes in and saturates the receptors, therefore leading to the overdose. So as a clinician, these symptoms, of course, will apply anywhere someone has an overdose, but in the clinical practice or in the hospital or out in the field, when you're identifying those, you should look for certain signs. And in this chart, what we do is we compare somebody who's really high to somebody who has an overdose. Pupils are pinpoint in both cases with opioids. It's commonly found with the heroin overdose or someone who's on heroin. If they're coming into the clinical practice, of course, with examination of the eyes, you should see that. The other things you should look for that's not on this slide is different behavior, paraphernalia, family history, or family concerned about abnormal behavior, criminal behavior, but that the patient's behavior has really changed, and maybe Anna can tell us a little bit about that. You can get nodding, of course, but the patient is usually arousable, of course, if they're just high on the medication, as opposed to with an overdose, you can't arouse them. Speech is slurred with opioids, especially with a significant amount, but with an overdose, it's very infrequent breathing with overdose. So you go from slurred speech to nodding to where the patient may seem like they're asleep to where they stop breathing. And a lot of these patients just are said to stop breathing in their sleep. And then at the bottom we see sleepy, intoxicated, but breathing when it comes to being really high. But when you overdose, the breathing is slow or stop, less than 8 times per minute, and you may hear choking or gurgling, and of course they can become blue on their extremities or around their lips. Narcan, and I'm going to let Jeff talk a little more about this, and Anna spoke about it in the availability now, and it's all reported because it saves lives, and it's a quick reversal. As you see, it works in 1 to 3 minutes, and it lasts 30 to 90 minutes to protect and to reverse respiratory depression. What it does is it knocks the opioids off the opioid receptors, and it only blocks the opioid receptors. It's not harmful. It can't be abused. It doesn't cause an overdose. Now, it can cause withdrawal symptoms if high doses are taken, but this will not cause any mortality. Temporary takes away the high, giving the person a chance to breathe, and it's only contraindicated if the patient is sensitive to Narcan. So I don't know. Those are receptors that kind of evaded us on the last slide. And let's see, you give the Narcan, and the Narcan knocks the opioid from the receptors, thereby returning respiratory function, and the patient can now breathe. So I'm going to turn it over to Jeff to tell you a little bit more about what's happening outside of the practice and what he's seen.
All right. Thanks, Dominic. Also, I want to congratulate Anna for being off. I think it's 9 months. I think is what I've seen. That's great. From the front lines, paramedic standpoint, when they asked me to do this, I've been a paramedic for about 15 years now. Ran up in the Dayton, Ohio area. I'm in Georgia now, but I ran up there for years. And it's one of the highest. They got the highest death rate right now in overdoses in the country, and we'll kind of go through that here in a few minutes of how they got there. But just to kind of take you from the front of what we normally see and what we would do. Normally you hear something like this. It could be 2 o'clock in the morning. It could be 2 o'clock in the afternoon. It could be any time of day. But normally we get dispatched, you're going to hear something like EMS 15, Medic 15, Medic 15-2, respond to a 17-year-old non-breather at 123 East 2nd Street. Caller states possible overdose. What's significant about a dispatch like this is the resources that are involved in it. When you look at the EMS 15, that is normally what we refer to as a chase vehicle. So that chase vehicle is maybe lieutenant, chief, somebody like that would be in that truck. And then 2 medics. Depending on where you're at, you may get a fire truck and a medic. Just depends on the area, where you're running, who's available, who's not available. But as far as resources go, you're going to get at least about 5 to 6 people that's going to be there. And from a Narcan standpoint, you're looking at about, well, and this was back in 2008. This is actually a dispatch I got in 2008, and I'll expand on it here in a little bit. But at this time in 2008, we get about 12 milligrams total of Narcan is what we had on scene. Just between every medic had about 4 in each drug bag. So when you get on scene, this is kind of what you'd see. It could be a nice home. It could be a home that maybe is totally wrecked. It could be an alleyway. It could be absolutely anything. The picture up on the left-hand side that you see, that's actually a real shot. That's exactly what you would see. That's a officer reaching in to try to pull the lady out. And this is typical, mouth open. They're going to be pale. They're going to be blue. They're eyes roll back. They give you that death. They may not have a heartbeat. Just depends on how long it takes you to get there. What a lot of people don't understand is we could get there, but it takes probably at minimum 15-20 minutes. By the time somebody recognizes they're down, they call 911, they dispatch us, we get in our medic and drive to the scene. You're talking 15-20 minutes at minimum. We know from ACLS and the advanced life support that brain starts losing, once you start losing oxygen after about 5 minutes, you're going to start losing brain cells. Okay, so there's a lot of, time that matters when we're going to these scenes. But that's typically what you get. When you get on scene, you're going to hear, I've heard all kinds of comments over the years, stuff like, is my mommy dead? I've heard that before. That's normally from a child, and this is a child back here in the back. You can see in the top left corner. Mom and dad both overdosed on it, and they know. They know, the kid knows, because they've either heard before or somebody's made a comment, so they know what's going on. And they'll ask you questions. Is my mommy dead again? That type of question. This is the first time my daughter's ever done drugs. I've heard that a couple times. Most people don't start with heroin. That's a pretty harsh drug to start with. They start with other, even as Anna stated, she started with other meth drugs. Of course, she made it to heroin. But a lot of times family members don't realize that, you know, how far along a person has progressed into the drugs. Yeah, just given that stuff you gave them last time, obviously this is Narcan they're referring to. I've heard this many times where, you know, we've given, you know, 10 milligrams of Narcan to somebody and they're still not being revived. So they actually have to have, you know, they'll tell us, oh, just give me that stuff. Well, we are, and it's not working this time. And then this is kind of my favorite. I heard this one time, and it just I didn't know what to say. And to paint the story, it was at a motel, and a lot of times with these drug dealers or drug areas where the patient is being, you know, I've seen tossed out on, you know, the family members' lawns. You know, some, you know, they may or may not be dressed. Just thrown out into the lawn. I've seen them thrown out in the middle of the street in front of hospitals. Because they don't want us to go into the apartment, because once we enter as EMTs, then so can the police enter. So a lot of times in a situation like that, they'll have the, you know, person out of the room or out of the house or drop them off somewhere so that they, you know, they can't be caught with the drugs. But this particular one was outside of a motel. The girl had her pants was about half down. She was actually thrown into a back seat. Her feet were still sticking out of the car. And totally unresponsive. She was breathing about 1, maybe 2 times a minute. She had vomited all over herself. She obviously had been laid out there, because if she had vomited, she'd aspirated everything, and we probably wouldn't have been able to get her back. And then from the door, the guy yells this: "I told you I'd take care of you, baby." So you know, those are the things. The rationale behind it. That was their idea of taking care was calling 911 and having somebody come in. So, you know, once we get on scene, you know, obviously we have to assess. I've walked into scenes before where I really didn't know, you know, who was my patient. I'd have 3 or 4 people. It could be a possibility. And, you know, with the one in 2008, the first call that I had mentioned on the first slide, we actually had that was a double overdose. The mother-daughter both had overdosed. The mother, it took right around 12 milligrams of Narcan to get him back, and it took the daughter 8 milligrams. That was the first time that we'd actually seen fentanyl mixed into the heroin. That was the first time we'd seen it in Ohio. And we were calling medics in, because again, we only had 12 milligrams on scene, which really by that time we had split between the 2 of them. And we were calling additional resources onto the scene just to get the Narcan. And I think we, you know, like I said, it was 12 for the daughter or mother and 8 for the daughter to get them back. So, you know, kind of looking at the timeline, Montgomery County, Warren County has kind of become, Montgomery County is Dayton, Ohio. It's right off of 75, and that whole area in there has kind of become really a hotbed for not just transporting the drugs in between, but actually the overdose. And, you know, everybody looks back and says, well, how did we get there? And it's not a new concept, a new thing that's taken place. If you look at the statistics, back in 2009, matter of fact, the call I went on in 2008 was kind of the instigator to bring in more Narcan. We, instead of carrying 4 milligrams per truck, now we're carrying 8 milligrams. So we increased how much we were given, or how much we had on hand, just to stay up with the amount of drugs that was being put out there. In 2012, they actually provided it to our police officers, which gave us another 4 milligrams. So now we're up to 12 on scene, just with 1 medic. And, you know, what we were finding, again, in that we had that big gap and that big span of how long it took us to get there. And if we're running on multiple calls, that's a big consideration. We had 3 medics in our jurisdiction that ran 2 cities and a township. So, you know, when we went on an overdose, if you take two in a chase truck out, you have 1 medic covering the other 2 cities and a township. So in 2015, they actually opened it up so now it was over the counter at Walgreens. Anybody could go in and get it. And then here in 2017, you know, Dayton, Ohio actually became, you know, per capita the #1 in the nation for overdose deaths. So even though we increased the Narcan and accessibility of it, the drugs that were being put out kept getting stronger and stronger because they knew they could reverse it. Most of the time, you're looking at a minimum of 4 milligrams to get somebody back. When you look at the heroin and fentanyl kind of side by side, you see that on the left-hand side here, this is kind of what we've always been referred to as a cap of heroin. And it's about 2 to 4 milligrams of Narcan. You could normally get a person back with that. If they're addicted to it, you heard him say that they can go through withdrawal. They will come up fighting. I've had that happen before several times. If you shoot it too fast, they'll come up swinging at you. And it's because they're taken directly out of that high, but also because they are oxygen deprived as well. And anytime any patient, I've had patients that tried to hang themselves before. When you take them out of that, get the oxygen back into their system, their brain's oxygen deprived, and they come up swinging. On the right-hand side there, you'll see the heroin and fentanyl, and you'll kind of see the difference in dosages. So on the left there, you'll see that that's about 30 milligrams of heroin opposed to 3 milligrams of fentanyl. So drastic. The fentanyl does not take much. One of the big issues that we're seeing with these drugs is the drug user don't know when the heroin is being laced. The drug looks the same. So they don't know the difference. And a lot of times, if they go into rehab, now they've been off of it for 2, 3, 4, 5, maybe even a couple of weeks. And when they go back, they go back to the same dose. Well, if it's laced with heroin, that same dose, that 1 cap or 2 caps that they may be used to taking that day, could very well, 1 cap alone could send them over the edge and put them into, and actually cause the death. So the dealers, other issues, the dealer is not being able to measure correctly. They don't know, their equipment's not fine-tuned, so they really don't know in a lot of cases how this is mixed. And so it's a guess in a lot of cases, and if they guess wrong, it becomes lethal. And when we see one death, we will see multiples in a row. There's been nights when we'll get one death, and then all of a sudden by the end of the night we're up to 10 or 15 deaths. And that's what you're seeing across the nation because the dealer measured it incorrectly, and he's passing it all out. So over a period of 24, 48 hours, you could have 50, 60 deaths. The street fentanyl is less pure than what you're saying. I think Dr. Mack referred to that as well. And then the heroin and fentanyl, they look identical. So really, a lot of times the user has no idea really what they're getting. In Ohio, one of the big issues they're having, this is starting to creep up, from Maryland all the way through, that you'll see is they're running out of room for the bodies. I mean, these are straight out of news reports and articles it was produced. They're running out. They're grabbing what we use as mass casualty trucks to put bodies in for mass casualty events. They're pulling them trailers out now and using them for these overdoses. So these are things that they're running into and starting to have more and more issues with. You see down here in Montgomery County, they started using they're renting space out at funeral homes just to store the bodies because they're having so many. So cost-wise and stuff, what are we looking at? Well, Middletown, Ohio, which sits just south of that Montgomery County line, they butt up to it, but it's that same area. Just in the first 6 months, I spent $100,000 just on Narcan. When you add in the resources and supplies, when I say supplies, everything from the bag, the needles, all that stuff, plus the manpower that is put it towards it, they're pushing close to $1 million to $2 million a year. They're adding into this to bring people back. And there's a couple, solutions that people have come up with, some good, some bad, and maybe Anna can expand on her thoughts on some of this. In Maryland, they started rationing out the Narcan, and they tried to select areas that they thought it may be, maybe we have an overdose over this area versus that area, and they put 10 milligrams there and only 4 milligrams somewhere else. But again, we don't know dosages, and if you get that one dealer in one area that has, that mixes it bad, we're running the risk. They've had schools that have started adding Narcan to their to have it on hand at the schools. This is an interesting one, and it has definitely sparked a lot of controversy. But they had a council member, and his argument for this was, we're spending. This is actually in Middletown, so they're spending up close to $1 million, $1 to $2 million on resources for repeated drug offenses. Many of these people have overdosed. I've had people that's overdosed, and I've brought back 6, 7 times myself. My other colleagues have brought them back multiple times as well. So it's nothing for a user to have been brought back 10, 15, 20 times sometimes, and continue to go back to the habit. So he proposed a 3-strike policy where after the 3rd time they're not going to issue the Narcan. I don't know if that's right or wrong, but that's one of the things he proposed, and obviously it's got a lot of controversy. But his rationale also behind it is, I'm spending $2 million of the city's money, taxpayers' money, and I have to take it away from other areas such as road improvements and jobs and stuff like that from other areas. So I'm going to have to start laying people off, and I'm going to have to start decreasing what services we have, and we're also going to have to increase property costs or taxes, and it's going to drive the housing income down. So that's his argument. He's saying, as this creeps up, these are the things that's going to have to be taken, in consideration to offset the cost of it. And then the other one that I found, which this is in Troy, Ohio, and then Troy is about it's kind of on the north side. So Middletown's on the south side, Troy's on the north side of Dayton. They recommended what they refer to as paramedicine now, or community paramedics, where they take a paramedic, they take a police officer and an addiction counselor, and they go out and they every Wednesday, and they follow up on the previous people they've saved. This has moved into a lot of different stuff too. I mean, community paramedicine is something that's started up where we start checking in on people and looking to see, how they're improving. In all areas, but I thought that was very interesting that they actually took, they're taking an officer out and going to these, and just to try to prevent future overdoses. So the other thing is concerned, and Fairborn, it is part of Dayton, Ohio. This is an area that as we increase what we do in trying to fix the issue, the dealers increase how much more potent the drug becomes. And it's to the point now where, the medics are wearing double gloving, they're wearing sleeves, and they're also masked even now. But here was 2 events where a police officer just had white stuff on it. He did a drug bust, he came out, he had white stuff on his shirt. He went to dust it off, and an hour later he had passed out. He actually overdosed. It was on fentanyl. And then the bottom one here, you see the firefighter paramedic overdose. That was on November 11th. So we're talking here recently. And this is actually a friend of mine was the one in the back with the patient, a fellow medic that I ran with a lot. And I called and asked him about this, and then he told me that what happened was they had taken care of the patient. The patient was fine. They got the patient back. She was in the back. and as he's driving down as they're going down the road, he's in the back with the patient. The medic started swerving, and he started calling up to his medic, and the medic's like, I can't see, I can't see, I can't see. And then all of a sudden, he just went unresponsive, and he actually had to climb through from the back to the front in front of the to get onto the brake to be able to stop the medic in the middle of a very busy intersection. And to get the medic stopped, then they obviously called resources and was able to issue him Narcan, which brought him back around. But it was just by a touch. So the fentanyl's getting so potent now that it's being absorbed. So that's kind of the take from the field, I guess.
Thank you both, Dr. Mack and Mr. Adams. We're now open for Q&A. And the webinar presentation can be found in a pod in the lower left corner of the screen, and the web resources, which are parts 1 through 3 of our opioid use management series, they can be found in the web resources pod. Feel free to submit your questions in the presenter Q&A pod, and we will also be taking questions from registration. How do you think, or how do you feel that smaller communities can address the opioid crisis when they already have limited healthcare resources?
I guess, Jeff, it's tough for not only small communities but the metropolitan communities, because no one has the resources. Let me say this: there are different type of funding mechanisms. Sometimes communities, municipal systems can get additional funding from the state according to the need, and of course there are federal grants and things of that nature which may take additional time. But that's why we think prevention, education, and training within the community, which is not that expensive, can really help. Let me just say this. Remember this, I showed the slide about in the 60s people were getting on heroin and then getting on prescription medication. Now it's the other way around. So the medical community is responsible for a lot of this. So the prevention can start there too, as far as the education and training, to make sure that we don't have a new generation to get on these drugs. Jeff, you got something? Yeah.
I also think that I'd be curious to hear Anna's perspective on it. As I listed 2 or 3 things that possibly they're doing to help from a stand. But if they had a paramedic and a police officer that came around and followed up on that, would that have helped maybe earlier in the process for her or not? I think that's really from our side of it. That's the best we can do at this point, is try to go out and follow up to make sure of it. But I don't know if it helped or not.
I believe Anna is still on, so she is available for Q&A. Anna, are you there? So we have a multi-part question for you. So the first question is, what do you think health professionals can do, or persons who are working to treat the opioid crisis in small communities? So what can be done in small communities or rural areas?
Definitely have the community reach out, have a lot of resources, places like where I'm at, Recovery Institute, and, a lot of meetings other than just AA and NA, because I know a lot of people that I am in recovery with now don't really agree with, don't really like AA or NA or how it's set up. And I think the main one is a lot of drug court programs. I've never seen a drug court program where you could voluntarily sign up. But it's a family drug court program, so it's to sign up through the family court. It's not just where you can sign up, on the streets without kids. It's when you're in the midst of having your kids taken. So I feel like there should be drug court programs where you can voluntarily sign up whether you have kids or whether you don't.
Phenomenal. So our next question is, well, actually you may have answered the next question, which is what would be effective strategies for college-age students, to effective prevention strategies for college-age students, excuse me, persons.
College-age students that are using?
Well, prevention before they use, and then effective strategies after use.
Right, so after use, I think I kind of answered that question too. It's just, you know, having the community reach out, having positive resources that you can have, and definitely making it aware in the community of the problems with drugs, so that, you know, people don't feel alone and stuff like that.
Yeah, this is Dominic. I agree with Anna, and I'd like to add that I think the leadership at the colleges and universities have to be aware that there's a significant problem among college students, and therefore provide those resources, fund those, put funding toward those resources, or partner with other organizations to make sure they bring those resources on campus or make them available to the students.
Mr. Adams, did you have anything that you wanted to add to that?
Yeah, I kind of agree with what they were saying. I think that the you know, having the resources and on campus are very important.
Okay, wonderful. Well, we are kind of reaching the top of the hour, so I will ensure that each of the webinar presenters have access to the questions which were submitted via registration and via the live event, and we will provide an email update with answers to questions and answers to topics and themes. But before we leave, I'll leave it to you, before we end, I'll leave it to you, Mr. Adams and Dr. Mack, to share your closing thoughts with the webinar attendees today.
Go ahead.
Probably some of the things is already said. I think prevention is really going to be the key going forward. We are in the place we are now because of, again, the overpopularity of opioid analgesics. You know, there's been statements about pharmaceutical companies didn't properly label and warn health professionals of the risk, but there's also, we as health professionals have been overprescribing and not paying attention to the needs of the patients in this area. So it's really taken a while to get to where we are, and I think it's going to take a while to get back off of this current epidemic, and that's going to really require that we put in preventive strategies. We have to have support for treatment, but we have to have primary and secondary prevention. And when I say second prevention, like folks like Anna, you know, once they get out of treatment, we can't just leave them alone. We have to continue to support them to prevent them from coming back into treatment, because Jeff spoke about, you know, the risk, and Anna surely knows the risk of, you know, going back to use again. So prevention, the primary care system, and public health, primary care providers, and all providers are going to have to be more aware. They're going to have to be better trained. We talked about these medicated assisted treatment programs that now, instead of having to go to a substance abuse center to get treatment for opioid addiction, it has to be more available within your local primary care practice. Just like we're making the Narcan available, the treatment, the prevention, the education, and training has to be available. So I would just say prevention is going to be a big key to the future of this epidemic. Jeff?
I kind of agree. I think you know, Narcan does great, and you know, if you get enough of it and you catch them at the right time, yeah, you bring a lot of people back. But the focus has seemed to be that I've seen, at least from a paramedic standpoint, is you know, let's make Narcan more accessible, and I don't think that's the answer. As it is that you know, we got to get some solutions out there of, you know, some following up of these patients, and some way of you know, treating them more like a victim than you know, oh, this is a drug user or whatever. And and addressing the real issue of, you know, how do we get the education out there, you know, before somebody starts onto them, and also how do we get them out there and get them away from it long enough that they can, you know, stabilize them like Anna has done, and you know, those are the people that really need to really invest in and look at and say, how can we, you know, get more people down that path, and is it take them away from the situation longer, you know, that is needed, or, you know, what are those issues? You know, obviously Narcan is a great, you know, Band-Aid for the immediate situation, but by far it's not, you know, something that is really taken care of, the issue itself. So I think, you know, putting the medics out there with police officers and you know, social workers, and getting it out there and following up on these patients and really treating them like, you know, more of a victim of the circumstance, and see, you know, what can we do to improve their situation and get them down the right path.
Thank you both, Dr. Mack and Mr. Adams and Anna, for being phenomenal presenters during this extremely engaging and informative webinar presentation. We invite each of you to complete the educational series. Part 5 will launch on December 13th, and that too will be CME accredited. On behalf of the National Center for Primary Care, we thank each of you for attending Part 4 of our Opioid Use Management webinar series.
Yeah, this is Dominic. I agree with Anna, and I'd like to add that I think the leadership at the colleges and universities have to be aware that there's a significant problem among college students, and therefore provide those resources, fund those, put funding toward those resources, or partner with other organizations to make sure they bring those resources on campus or make them available to the students.
Yeah, I kind of agree with what they were saying. I think that the you know, having the resources and on campus are very important.
Go ahead.
Go ahead.
Probably some of the things is already said. I think prevention is really going to be the key going forward. We are in the place we are now because of, again, the overpopularity of opioid analgesics. You know, there's been statements about pharmaceutical companies didn't properly label and warn health professionals of the risk, but there's also we as health professionals have been overprescribing and not paying attention to the needs of the patients in this area. So it's really taken a while to get to where we are, and I think it's going to take a while to get back off of this current epidemic, and that's going to really require that we put in preventive strategies. We have to have support for treatment, but we have to have primary and secondary prevention. And when I say second prevention, like folks like Anna, you know, once they get out of treatment, we can't just leave them alone. We have to continue to support them to prevent them from coming back into treatment, because Jeff spoke about, you know, the risk, and Anna surely knows the risk of, you know, going back to use again. So prevention, the primary care system, public health, primary care providers, and all providers are going to have to be more aware. They're going to have to be better trained. We talked about these medicated assisted treatment programs that now instead of having to go to a substance abuse center to get treatment for opioid addiction. It has to be more available within your local primary care practice. Just like we're making the Narcan available, the treatment, the prevention, the education, and training has to be available. So I would just say prevention is going to be a big key to the future of this epidemic. Jeff?
I kind of agree. I think Narcan does great, and if you get enough of it and you catch them at the right time, yeah, you bring a lot of people back. But the focus has seemed to be that I've seen, at least from a paramedic standpoint, is let's make Narcan more accessible, and I don't think that's the answer. As it is that we got to get some solutions out there of some following up of these patients and some way of treating them more like a victim than oh, this is a drug user or whatever, and addressing the real issue of how do we get the education out there before somebody starts onto them, and also how do we get them out there and get them away from it long enough that they can, stabilize them like Anna has done, and those are the people that really need to really invest in and look at and say, how can we get more people down that path, and is it take them away from the situation longer that is needed, or what are those issues? Obviously Narcan is a great band-aid for the immediate situation, but by far it's not something that is really taken care of the issue itself. So I think putting the medics out there with police officers and social workers and getting it out there and following up on these patients and really treating them like more of a victim of the circumstance, and see what can we do to improve their situation and get them down the right path.